السلام عليكم. في البداية أحب أشكر المنصة الكريمة ومستشفينا العام وعلى رأسهم أقسام الباطنة والدكتور عبد الرؤوف حافظ رئيس أقسام الباطنة والدكتورة جيهان وجميع الزملاء والحاضرين. Actually my talk regarding do not attempt resuscitation. Anybody hear about this concept? Okay, we'll try to put some highlights regarding these points. I have 3 messages to be sent for you. Message number 1, ICU admission criteria. We have criteria for admission to ICU. Number 2, CPR is not an automatic action. It is a therapeutic decision. Number 3, DNR order is if you cannot help, please do not hurt. I will ask about these messages later on. Regarding the history of ICU, started long time ago, since 1850, when they noticed that critical ill patient or unstable patient, when managed near to the nursing station, the outcome is better. Later on, an eminent neurosurgeon, he did a great job. He was skillful surgeon, doing meticulous operations, and later on, post-operative, the patients with high mortality. When he bought a specialized area for monitoring of these patients, he achieved, previously mortality was around 8 out of 10, but after continuous monitoring, the mortality decreased significantly. And all these elements highlighting the importance to put particular attention to critically ill patients. What do you think about this picture? Anybody from junior staff? I know my seniors know that. Actually, this is iron lung, yes. This is a previous ventilator. When they started to initiate mechanical ventilation, they are putting a patient in this iron box and depending on the baseline physiology of negative pressure ventilation. Nowadays, we have this ICU, complex, meticulous, very, very expensive service. Actually, with this expensive service regarding spacing, regarding stuffing, regarding staffing also, all these equipments, knowledge, do we get any benefit from that? Should be yes. Yes, exactly. This sigmoid curve, a very famous curve in medicine. We have lower inflection point and upper inflection point. If you are working for any problem in the medicine, between lower inflection point and upper inflection point, you are achieving good outcome. While if you are working in the lower area or the upper steep area, you are not achieving anything. This is what happened exactly in studying more than 30,000 patients according to SAPS score, Simplified Acute Physiology score system. When the patient managed in the ward on the same parameters, the mortality is around 100%. When managed in the ICU in the same parameters, the mortality decreased by 50%. And this is a good achievement. For this reason, do we need more ICU beds to save more patients? And what is the criteria and how many beds you need in your hospital? Actually, it's based on your hospital capacity, your hospital classification. Is it teaching hospital? In UK, the standard there in teaching specialized hospitals, you need 1 to 10. 1 ICU bed for every 10 beds in the regular beds. And this is the current situation. It was previously 1%, and now we're achieving 10%. In the near future, we need 30% of the hospital beds for ICU only. Okay, so we need high number of ICU to admit patient to get outcome. Is it true? No. Why that? Because if you are admitting patient to ICU not indicated, you are not helping the patient. You are not helping the company, the community. You are not helping your nation. Actually, you put increase in the invasive, potentially harmful procedures, investigations, length of stay, cost, increased mortality even if you are admitting non-indicated patient to ICU. And another big problem, you are consuming your resources, so when you need ICU bed, you'll not find ICU bed. So we need to have a selection criteria, who will benefit, who will not benefit from ICU. And a lot of models we have for ICU admission. We have priority model, we have diagnosis based model, we have objective assessment model. I'm going quickly because we have short of time. For priority, we have priority number 1. This patient going directly to ICU. Who is that patient? He is critically ill, unstable patient, need invasive mechanical ventilator, need vasoactive drugs, and no therapeutic limitation. This patient, I will put every effort for him to save his life. Like whom? Like a trauma patient, like post-operative patient, like acute respiratory failure for some reason. So this priority number 1. Priority number 2, this type of patients requiring monitoring, they are currently stable, like patient with stable heart failure, a stable respiratory problem, chronic respiratory disease, and then developed, or chronic kidney disease, developed acute illness like surgical or medical, and he need invasive monitoring, need meticulous monitoring. This patient needs ICU. Priority number 3, like chronically ill patient with less likelihood for survival, like METS patient in advanced cancer disease and then developed acute issue like infection, pneumothorax, significant pleural effusion. This patient might need admission to ICU for short period of time, but with limited ceiling for the service. You'll not do everything for this patient because the likelihood for survival, like according to the plan and from the oncology, 6 months or 1 year, 2 years. So you'll not put a huge effort, especially with this likely of recovery. Priority number 4, actually this type of patient should not be admitted to ICU. Who is that? These patients too well to benefit from the ICU. They are good. They can be managed. They are still patients. They can be managed in the regular ward, not in ICU. Or too ill to benefit from ICU. This patient is very in reversible stage of disease, so will not benefit whatever effort you do. So this type of patient should not be admitted to ICU. Regarding the diagnosis-based model, according to the diagnosis and the patient instability, or objective parameters model based on acute changes in the patient situation. Anybody know this guy from the General Hospital? Yes. This is Mr. Hamada, 26-year-old. He's a nurse supervisor in our ICU. He's very active man. Actually, ICU is based on good nursing staff. And one of them is Mr. Hamada. Mr. Hamada, he was working in the ICU last year, doing his night shift, caring the patient, and suddenly collapsed inside the ICU. What should be the immediate action? Call for help, CPR. And then CPR done for him, requiring intubation, mechanical ventilation. He achieved ROSC, and later on found to have significant bradycardia and sinus node dysfunction, and currently has a permanent pacemaker and working still in the ICU. Good achievement for CPR. So the history of CPR started long time ago, from 1711, going through up to our modern CPR started in 1960. When these guys developed a technique for closed chest cardiac massage. Previously it was open cardiac massage. Actually, if you notice the names, you surprisingly, most of them are engineers, not doctors, only one medical student there. And they achieved survival for 14 out of 20 cases. Did CPR for them from closed chest compression. And they put a statement, anyone, anywhere can initiate cardiac resuscitative procedure. All that is needed, only 2 hands. You need only 2 hands to do CPR. And since then, the CPR and a lot of guidelines and updates every now and then for CPR. And currently, CPR is the default for almost everyone developing cardiac arrest. Everywhere you might find AED, even in airplanes you will find an AED. The question is, should this remain the case? Should we continue since 1960 like this? أنا ICU جاي تقول ما تعملش CPR ولا إيه؟ This is a real case scenario. Actually, I encountered this scenario when, during my residency in Alexandria University Hospital. A 30-year-old female, mother of 4, with metastatic breast cancer, lung, bone, brain mets, on the plan on comfort care, presented to our ER with worsening respiratory distress, desaturation, disturbed conscious level. She was brought in by her caring close relatives, her husband, father, and brothers. What is the best action for this patient from the internal medicine resident? A, call ICU urgently. B, admit to internal medicine ward. C, discharge her home from ER. D, transfer to Cancer Institute. And E, call his senior specialist. What do you think? Who's vote for A? Only 2. Actually, it's very difficult situation. And reflecting our practice. Yeah, this reflecting our practice. Actually, it was maybe 2003 or 4 like this. And we are still continue same practice, unfortunately. This is a good statement. Think of CPR like surgery. We would never say that a bed-bound, critically ill or chronically ill, debilitated person should immediately go into surgery if they have an emergency surgery. Same like CPR, same like your plan for your patient. We have pros and cons for CPR. CPR, like what we did, and great achievement for Mr. Hamada, can be very successful to revive somebody from death, provided the underlying organs, his organs, lung, brain, heart, are capable of sustaining life after a short period of resuscitation. Number 2, you have reversible cause, or cause you can fix it, like you have patient with arrhythmia and you can fix this arrhythmia. On the other hand, CPR has evidence low initial success rate. For out of hospital cardiac arrest, only 8%. For in hospital cardiac arrest, you can achieve like 20% for survival. Again, very low survival rate till hospital discharge. If your patient, you achieve ROSC and the patient to be discharged home, less than 50%. CPR is a traumatic procedure. Almost maybe 100% rib fracture, 50% sternal fracture, 5% internal organ injury. CPR can prolong the dying process, death process. So, are we creating survivals or victims? The media, TV, the spotlights regarding doctors, healthcare practice, including resuscitation and CPR. All of us saw many movies covering this point, or highlighting this point. And a good study actually putting a conflict between what people say watching in TV and movies and the real life, and add on in our healthcare system. Survival immediately after CPR achieved they collecting all movies and series, 77% recovery. Long-term survivor around 70%. CPR in patients suffering from heart disease, 28%. And cardiac arrest etiology was trauma. Age, most of them children and young adult, which is opposite for our practicing our daily in the hospital. And putting another conflict between population and healthcare. So, to summarize, we have cardiac arrest either sudden, unexpected, or a final common pathway for dying process. How can you make a decisions? The starting point for reaching good decisions is careful consideration of the patient's clinical situation, not only the diagnosis. Through a thorough assessment and likely prognosis. In each chapter in your book, you will find for any disease parameters of the bad prognosis. You should study it. Treatment options based on the updated clinical evidence and relevant clinical guidelines. Early consideration and planning for your patient, like our real case scenario. This patient should, from the start, should be clearly told to the patient and her family. For comfort care, what does it mean, comfort care? If cardiac arrest will not do anything, it is not candidate for ICU, so only for just pain relief secretion like this. You need to seek a second opinion. It's not shameful to have second opinion. So, when encountered a patient and your decision, CPR and resuscitative effort will not restarting breathing and circulation, will not help your patient. What is your decision? You need to sensitively discuss this with the patient family and do not withhold information simply because it is uncomfortable for you or your team. Actually, we have a conflict ethically, akhlaqiyan, legally for these issues. If you are not respecting the evidence-based medicine, you are hiding information. You are giving a false hope. You are prescribing a useless treatment. You are achieving very low cost-benefit ratio. You are doing unjustified harm. You are causing patient physical and psychological suffering. تتكلم مع المريض ولا أهله، لا روحوا اعملوا الأشعة دي، روحوا اعملوا الحاجة دي. أنت put them in suffering. I have in my hospital a young girl like 9 years, severe traumatic head injury. She is brain dead, and going to somewhere seeing CT and or MRI, requesting more CT, more investigation. Why? What is the benefit? Making a big conflict between doctors, between the administration, and nowadays in the media. Promoting unjustified death. Why? Putting the patient, he's going to die, definitely, from your experience. So why he will go to death with fractured ribs, with injuries, with pneumothorax hugely inflated. You are aggravating the family stresses, disregarding the patient's last wishes from our culture. Most our babas and mamas said, let me die at home. And doctors insisting, no, stay at hospital. Creating confrontational working environment, exporting local and national troubles, wasting and misallocation of the family and national resources, depriving someone else in need of life-saving services, losing trust in the healthcare system. ده حلال ولا حرام؟ We are not alone in the world. مين هيسأل التاني؟ We are not alone in the world. Although we don't have any policies, procedures, legislation in Egypt regarding the DNR, it's long time, but unfortunately it is not applicable in 100% of situation. Like in UK study done for two weeks, and they found in around 85% people underwent CPR actually would be labeled DNR beforehand. We have a good experience regarding Saudi Arabia, بلاد الحرمين. Since 1988 there's a fatwa from high authority اللي هو المجلس بيسموه ايه؟ هيئة كبار العلماء في السعودية من 1988. They issued a statement regarding if 3 knowledgeable and trustfully physicians agree that the patient's condition is hopeless, life-supporting machines can be withheld even or withdrawn and the family members' opinion is not included in decision making, as they only 2 minutes, just only 2 minutes. And from there, a lot of investigation done. They need education, and this is study done actually from the internal medicine resident. Where we are in Egypt, actually, the first publication regarding DNR, it was in 2010 in Alexandria Nurses Faculty of Nursing. This is the first one I could find, and later on, actually, the most one recently published in 2020, done in Ain Shams, and their conclusion: absence of definite legislation and guidelines for end-of-life care in ICUs and Ain Shams University hospitals was the main influential factor for ICU physicians' practice and attitude toward limiting life-sustaining treatment at the end of life. And their recommendation for that, we need education and training for this important topic to save your patient and save this valuable ICU bed for when needed, and to decrease the demand regarding the ICU beds. So what were my messages? ثلاثة. Who could memorize? ICU admission criteria. So every hospital should have a clear criteria for ICU admission, so not making conflict between specialties. Number 2, CPR, not immediately just go and do CPR. You should put a plan for your patient when examining your patient, assessing your patient. Be clear and honest with the patient and family, including CPR. And you could label the patient DNR. We need to work actually in a national issue regarding the legislation and rules for CPR. Thank you.